Good afternoon and greetings to all. I am Dr. Devanshu Kalra and I am here to present my topic on FTM, female to male top surgery, all we need to know about the broad topic. So, starting with the basics, how many types of gender are there? Basically, the gender identity is one's sense of self as male, female, or both. So, cisgender and transgender. So, cisgender would be the gender identity when it matches with the assigned birth sex, and the transgender, it is an umbrella term when the gender identity is different from the assigned birth sex. So, population-based studies. Around 0.5% of the population in US and 0.7% in Netherlands have been seen to be under the transgender umbrella. And talking about India, if we talk about figures, in 2011, there were around 4.88 lakhs of transgender population comprising of 55,000 children also. So, talking about the neural basis of transsexualism, that is, transsexuals usually identify themselves with a psychological sex that is opposite to their physical sex, and hence they feel trapped in the wrong body. So, it is seen to be strongly associated with the unusual neurodevelopment of the brain at fetal stage. As per the 2016 review, for trans men, the research indicates that those with the early onset of gender incongruence have brains that generally correspond to the assigned sex, but that they have their own phenotype with respect to the cortical thickness, subcortical structures, and white matter microstructures, especially in the right hemisphere of brain. Talking about the nomenclature, first, initially, according to the DSM-4 criteria, the term was introduced as gender identity disorder, which was termed as a psychiatric diagnosis when a strong and persistent cross-gender identification combined with a persistent discomfort with one's sex or sense of inappropriateness in the gender role of that sex, which causes a clinically significant distress. This term in 2013, according to DSM-5, was replaced with gender dysphoria. In 2018, according to ICD-11, all trans-related categories were deleted from the ICD chapter on mental and behavioral disorders, and the new term gender incongruence was depicted, which refers to a person whose sex assigned at birth, that is the sex assigned by a physician at birth according to the external genitalia, does not match their gender identity, that is one's psychological sense of their gender. But some of the patients with gender incongruence may experience gender dysphoria as well. Significance of FTM top surgery is basically the breast is a very prominent feminine structure that can cause significant dysphoria in individuals who do not identify as female. Top surgery is an important step in female to male gender reassignment process, and often the first and only surgery that many patients will undergo. So, a firm diagnosis for the transsexual condition needs to be made first, and the criteria for that are a sense of discomfort and inappropriateness about the one's sex, a wish to get rid of one's genitalia, and the desire to live as a member of opposite sex. That discomfort or disturbance has been present for a minimum of 2 years and is not limited to a period of stress. The patient has an absence of physical intersex or genetic abnormality or a mental disorder such as schizophrenia. There are requirements of referral letters from mental health professionals. One letter is adequate for instituting the hormone therapy or for the breast surgery, and 2 letters have been seen to be required from the mental health professionals before carrying out the genital surgery. The documentation that the patient acquires from the mental health professional should mention these 7 points, which include the description of a patient identifying characteristics, initial and involving gender, sexual and other psychiatric diagnosis, the professional relationship of the mental health professional with the patient, the number of consults, the type of psychotherapy or evaluation that the patient underwent. Eligibility criteria, it should be specified that those have been met, and the rationale for prescribing the hormone therapy or surgery. Degree to which the patient has been seen to show the compliance with the standard of care, the mental health professional, whether he or she is a part of gender team or not, and that the mental health professional, whether he or she would like to receive a phone call regarding the confirmation of authenticity of the letter. Coming to the hormone therapy, usually it is given for 6 months, and it is very important for a smoother gender transition, both physically and psychologically. When physicians administer the androgens to biologic females, patients appear more like the member of their preferred sex. The eligibility criteria for hormone therapy would be the age should be 18 years or above, in-depth knowledge of what hormones can achieve medically, their social benefits and risks, a documented real-life experience of at least 3 months prior to the administration of hormones, or a period of psychotherapy according to the specification of mental health professional, which should be a minimum of 3 months. Coming to the consents, basically 4 types of consents are usually required for these kind of surgeries. First and foremost important is the procedure specific consent form that should include a description of the surgical procedure. It should mention the surgical and anesthetic complication that might arise, and also the cost estimate of the procedure. The second is the waiver of liability form that waives the liability on the surgeon from the change of sexual appearance regarding long-term use of hormones and the irreversible change that will happen in the current sexual functioning. In rare cases, the patient might be already married, then he or she might require a spouse release form. If the patient is less than 20 years of age, they would require a parental consent form too. This is what the consent form would look like. Although the waiver of liability and these consent forms are available, but yes, there is absence of legal backing, so we prefer to convert these consent forms into the affidavits. Post-operative issues is just regarding the change of names in various certificates, identity cards and passports. Coming to the surgery, the goal of the top surgery is to regarding the masculinization of the chest, and that can be achieved by removal of the breast tissue, skin, appropriate nipple positioning, obliteration of IMF and the chest wall scar minimization, and appropriate chest contouring. Coming to the techniques, the 2 main techniques are the keyhole surgery and double incision free nipple graft, which we call as DIFNG. The keyhole surgery is basically an inferior hemiareolar subcutaneous mastectomy, and the second is the elliptical DIFNG is an elliptical mastectomy with a free nipple graft. So which one to choose? The 3 basic main factors regarding this are the breast ptosis, inferior vertical skin pinch, skin elasticity. So to create the breast ptosis, of course, we use the Reynolds classification. If according to the Reynolds classification, the breast ptosis is in under grade 0 or 1, then we'll go for inferior vertical skin pinch. If it comes out to be inadequate, the patient is of course the candidate for a keyhole surgery. And if it is not, and that means the adequate vertical skin pinch is there, we should look for skin elasticity, that is the presence or absence of any stretch marks also. So if skin elasticity is good, the patient can be done a keyhole surgery, else the patient is a better candidate for DIFNG. Regarding grade 2 and 3, we should go for double incision free nipple grafting. Some other additional indicators are whether the IMF is well formed or rudimentary, whether the breast disappear when the patient is lying supine, and the patient preference, of course. Regarding the keyhole technique, we are injecting the tumescent solution and initial liposuction, sharp dissection of the areola to dissect the NSE and preserve 5 mm thick button of the breast tissue. Subcutaneous dissection is then carried outwards and breast gland is removed. Obliteration of IMF is of course done, and after that tunneling with minimal suction to smoothen out the contour and feather out the edges of the dissection. Pocket is irrigated and meticulous hemostasis is done. Closure is done with the absorbable sutures and the suction drain is placed, and the dressing is done and the surgical binder is prescribed. So here is a case of preoperative view for a case that we have done a keyhole surgery for, and this is the intraoperative view of the patient. Patient specifically didn't want the reduction of projection of the nipple in this case, so we didn't touch the projection, not reducing the projection of the nipple. This is a 3-month follow-up for the patient. So coming to the second technique, double incision free nipple grafting, the tricky part in this case is the NAC position. So we should mark the NAC position. This can be done with like 2 anatomical measurements, that is thorax circumference and the sternal length, that is from notch to xiphoid. According to that, the vertical nipple position comes somewhere between 13 to 15 according to the thorax circumference, and horizontal nipple position comes somewhere between 10 to 12 centimeter. Yeah. So the placement of NSC also should be guided with the aesthetic judgment also. Some of the errors that can happen regarding the NSC placement would be nipple placed too close together, too high, or directly on the horizontal scar. So typically in the operation theatre, the inferior edge of the nipple should lie at least 5 centimeter above the horizontal incision and 10 to 12 centimeter from the midline of the sternum. In larger breasts, we tend to keep a bit lower nipple position because after the OT, due to unweighing of the breast, and the skin tends to retract upwards too. So the surgery begins again with the injecting of tumescent solution. NSC graft harvest is done. The male areola that is marked around 2.2 centimeter in diameter. Liposuction is performed and it gives the better plane for removal of the gland portion. Liposuction is performed with the equivalent goes to the keyhole technique. Superior incision is marked straight across the breast at the level of inferior border of the pectoralis muscle, while the surgeon uses his palm to pull the breast down. Then the incision is carried laterally, gently angling up towards the axilla. Medially, the incision is stopped around 2 cm from the midline with the corner angled slightly upwards. In cases of larger breasts, both of the incisions in the midline can be connected, giving it a gull-wing or inverted V appearance. Pectoralis fascia should be preserved, and during resection of the breast, all of the axillary tail should be included. Else it will lead to unnecessary undesired fullness in the postoperative period. Absorbable progressive tension sutures are taken, nipple grafts are thinned and with the scissors and then grafted as a single unit. Finally, tunneling is done again to ensure the smooth contour. A chest binder is given for 4 weeks and weightlifting is restricted for a minimum of 3 weeks. This is a case of DIFNG that we have done. You can see the 15th day post-op with slight redness on the incision sites as well. This is a 3-month follow-up of the same patient. Another case with the huge, large and ptotic breast that we have operated for double incision surgery and a 3-month post-operative review. Some of the complications that we have seen and the revision surgery's indication. In the keyhole technique, usually a hematoma and seroma can form. Of course, we insert a drain to lessen the chances of that, but yes, it can happen. Nipple creases and skin laxity, of course it can happen, but those patients are actually better suited for a DIFNG surgery. So the choice of the surgery should be appropriate. In the double incision surgery, partial or full necrosis of the nipple graft, which causes delayed healing and hypopigmentation of the NAC complex, that happens usually. Revision in the keyhole surgery, it is mostly not, but if done, it is only for the nipple projection if the patient is not convinced with that, and can be done with the local anesthesia as well. Revisions in the double incision surgery can be done only for the minor aesthetic improvements such as asymmetry, scar or dog ear correction. So here we can see some of the complications that I had in the cases. In this patient, this is a 20-25 day post-operative picture of the patient, and it is showing the almost complete necrosis of the nipple graft, and that caused the hypopigmentation in the nipple in the long term, for which we did micropigmentation of the patient to give the color to the nipples. This patient actually came for keyhole incision surgery, specifically insisting on a keyhole incision surgery. This is a 25-day post-operative view of the patient. So nipple creases, some skin redundancy is also there, some hypopigmentation is also there. We expect the hypopigmentation to be there due to excessive liposuction maybe, and it is almost expected to go after like 2 or 3 months. Skin looseness and nipple creases are also can be reduced with time, and also the appropriate massages. So the keyhole surgery technique has a higher aesthetic rating, of course, than a double incision surgery due to almost invisible scar pattern in the keyhole when compared to double incision. But the difficulty in comparing the techniques beyond complication is just that the indication of each are very different, and most of the patients who are actually FTM coming for FTM surgeries are actually not the keyhole candidates to begin with. So for them, the best result obtainable is with the double incision free nipple grafting surgery technique. Thank you.
Thank you, Dr. Divanshu. Thank you for the lunch session.
Thank you, sir.
Welcome you all in my presentation, that is cutaneous malignancies of management of cutaneous malignancies of face. The cutaneous malignancies of face, they are heterogeneous group of cancer that account for 1 to 2% of all diagnosed cancers in India. And there it is categorized into two groups. One is melanoma skin cancer and other are non-melanoma skin cancers. The non-melanoma skin cancers, they account for around 80 to 90% of malignancies. So I talk with focus on the management of these non-melanoma skin cancers. Non-melanoma skin cancers, the basal cell carcinoma and squamous cell carcinoma, they collectively account for 99% of these malignancy, and basal cell carcinoma is most common cutaneous malignancy worldwide. And it accounts around for 70 to 80% of non-melanoma skin cancer, whereas the rest is constituted by the squamous cell carcinoma. And 80% of these malignancies usually occur after age of 40, and 80% occur in people aged 60 or older. Coming to etiology, the skin UV radiation exposure is important risk factor, mainly the UVB radiation exposure. Other risk factors include the exposure to radiation, Fitzpatrick one skin type, indoor tanning, history of moles, basal cell nevo syndrome, and weakened immunity, particularly after immunosuppression patients after organ transplant or other malignancy. So coming to BCC, they constitute 80% of head and neck cancers. They are slow growing, indolent neoplasm, and they are locally infiltrative. So also we also call them as rodent tumor, and they rarely metastasize. So the types, they can be of nodular type, superficial spreading, pigmented type, morpheo BCC or basosquamous. Similarly, the squamous cell carcinoma, they are arise in sun-exposed areas such as head, neck, dorsum of hand, lip, and pinna, and they are more common in males in contrast to BCC, which are more common in females. The squamous cell carcinoma usually arise from precursor lesions such as actin keratosis, Bowen's disease. These are the pre-malignant conditions from which this arises. In contrast to BCC, they had higher tendency of spreading. The nodal metastases occur in 3 to 5% of cases, with mortality estimated 1 to 2%. The clinical presentation, it may present as induration with central ulceration, it may present as fungating growth, it may present as the nodular growth with central ulceration, or as a cutaneous horn. As far as these malignancies are concerned, there is S zone of the face, which include the nose, the lips, the periocular and preauricular region. This zone is called high risk zone, as the tumor arising from this zone have higher chances of recurrence and tumor extension. So the risk factor for the basal cell carcinoma is size greater than 6 mm in S zone and 10 mm in other areas. Poorly differentiated borders, immunosuppressed hosts present of previous irradiation, and perimural invasion are the other risk factors. Similarly, high risk factors for squamous cell carcinoma, tumor greater than 2 cm, bone invasion, anatomical location of ear or lip, thickness greater than 2 mm or beyond fat, that is Clark's type 5, or perineural invasion. So the biopsy from the diagnosis, the biopsy is the gold standard. Biopsy and histopathology is the gold standard. The BCC rarely metastasize, so metastatic workup is not necessary. But in squamous cell carcinoma, the regional lymph node should be examined in all the cases. And coming to the treatment option, the surgical treatment are the gold standard. They consist of the standard excision with margins of normal skin, and other is the Mohs micrographic surgery. Various studies have compared the result of the standard excision with Mohs micrographic surgery. And more micrographic surgery is found to be more useful as far as the tumor preservation of normal tissue and tumor recurrence. However, the results are not statistically significant difference. And the non-surgical treatment options, they are fluorouracil, imiquimod. These are FDA approved treatment for the treatment of BCC. Other treatment options are photodynamic therapy, electrodissection, cautery, but they are not preferred. So coming to the surgical margin in standard surgical excision, for low risk malignancy, in case of BCC, the surgical margin should be 4 mm of normal skin. And for high risk malignancy, the margin should be more than 4 mm, usually 6 mm. And for squamous cell carcinoma, for low risk, the normal skin margins should be 4 mm, and for high risk, there are 6 mm. And the treatment cure is about 95% after 6 mm margin in case of high risk cancers. If the lymph node came out to be positive, then formal lymph node dissection should be done in all the cases. And if the lymph nodes are palpable but came negative on biopsy, then 6 monthly follow-up should be done in these patients. So coming to my experience for last 1.5 years, I have treated 67 patients of cutaneous malignancies, 58 BCC, 8 squamous cell carcinoma, and 1 malignant melanoma. The most common area involved is the temple region, followed by the forehead, then is the infraorbital region. And the most common done flap in these malignancies is the limbal flap. As we all know, the cutaneous face is highly vascular, and all the random, these all are the random flaps, and they all survive well, provided we preserve the subdermal plexus by raising the flapping subcutaneous plane. So, coming to the planning of this limbal flap, whenever we raise the limbal flap, the short diagonal of this flap should be parallel to the line of maximum extension, so that the donor site can, the donor defect can be closed primarily without any tension. So this is the case 1. This is a large BCC of the face. After wide local excision, the limbal flap is placed from the adjoining thick area with short axis parallel to the line of maximum extension. And in this, second thing is old age patients, the skin is very lax. So the closer it come very easily. It look quite difficult on table, but it come at the end it come easily. This is another patient with large basal cell carcinoma of the temple region. This is the defect created, and the limbal flap is bland. And these are the post-op pictures. This is 10 days post-op, and this is 1 month post-op follow-up. Again, the limbal flap done over the infraorbital region. In this patient, the limbal flap is done in the lateral wall of the nose and the infraorbital region on medial aspect. In this case, the limbal flap is done over forehead. With time, I have started doing circular modification and other modification of the limbal flap also. In this, I have done a circular modification, and these are the post-op results. This again, the BCC of the infraorbital region and oblong parallelogram flap, another modification of the this rhomboid flap, and again the limbal flap is done in the chin region after wide local excision, taking care of his this weird hair direction. Again, a patient of BCC of the cheek, and the result is so nice that it is hardly scar is hardly noticeable. Sometimes the defect is large, so it never comes with a single flap. So we can plan 2 limbal flaps in this patient, one from superior and one from the inferior side, and these are the post-op results. This is another patient of basal cell carcinoma of infraorbital region involving extending up to medial canthal. A mustard cheek flap was raised, and these are the post-op results. Another patient with squamous cell carcinoma of base of the root of nose and of the lower eyelid. Here the VY advancement done for lower eyelid and graft was placed over forehead. Another patient treated with VY advancement flap. This is another patient treated with lateral nasal flap for the nose over the dorsum of the nose. This is another patient where a binode flap was planned for after excision of BCC. This is another patient where the defect is closed by VY advancement flap. This is a defect created after the excision of the BCC of the ear, and the post-auricular skin flap was used for lobule reconstruction. Another patient of BCC of the ear lobule and post-auricular flap was done. This is another patient with large fungating squamous cell carcinoma of the nose treated with a forehead flap, but unfortunately that patient lost follow-up didn't came for pedicle division. And coming to follow-up, the patient of BCC are at 10 times risk of developing further BCC than general population, and 95% of recurrence of squamous cell carcinoma occur within 5 years, with 70 to 80% occurring within first 2 years. So NCCN recommendation is 3 to 6 months follow-up for first 2 years, then 6 monthly for 6 to 12 monthly for next 3 years. Thank you.
Thank you, Dr. Mummy, for a nice talk. Questions in the lunchtime?
Good afternoon. First of all, I would like to thank the organizers for such a nice organized conference and giving me the opportunity to present my work. My topic is use of flexor hallucis longus tendon in certain cases of tendo-Achilles repair, because I find that it is a very useful tool in certain situations that are very tricky. So tendo-Achilles is the largest tendon of our body, and its importance in the gait cycle is well known. But unfortunately, when it is injured, the injury and the treatment as well, it causes a lot of problems, and sometimes the treatment is not straightforward, and giving a primary healing is difficult. So with that intent, I started this study and started using the flexor hallucis longus tendon. So the causes of injuries are many. Most commonly it is caused by sports related injuries, and other common causes, and which are the common causes in my study, are tendinosis in elderly population, and not only tendinosis, the treatment of tendinosis by triamcinolone injection, and apart from that, accidental entrapment of the foot. The main cause of tendo-Achilles avulsion is sudden dorsiflexion of plantar flex, and even neutral foot, if it is dorsiflexed violently, the tendo-Achilles can come out. For patients who are osteoporotic, who have had steroid injections, even a trivial trauma can take out the tendo-Achilles. Then the injuries may be open or closed, with loss of tendon, without loss of tendon, and sometimes they appear or they come after more than 6 weeks of injury, which is called the delayed presentation, and sometimes the injuries are either complete and sometimes they are partial. So on one end of the spectrum we have an avulsed tendon in a middle-aged or elderly female who has had steroid injection, and the gap is more than 3 centimeters, and on the other hand there is an acute injury. It's a sharp injury in which the tendo-Achilles, all the peronei, the tibial artery, the tibial nerve, posterior artery, all are transected. Just to look at it, the right sided patient looks a graver injury, and it is a graver injury definitely. But for a surgeon, I think the other one, the acute one, is easily manageable when we compare it with the chronic injury. The treatment or modalities are many, conservative including casting or bracing, end-to-end repair, which should be the gold standard, percutaneous repair, reconstruction with VY advancement, or turn down of the proximal tendon. Then we can augment, it is an accepted treatment modality, augment with the flexor hallucis longus tendon or peronei or FDL tendons. And for cases with a large gap or large defect, we can use free ALT or free gracilis with or without facial attack. The complications, as we discussed, are many. Dehiscence of repair, it is clinically seen by the inability to stand on the tiptoes in the follow-up, sural nerve injury. But the complication that I am concentrating is the wound healing complication, which has a very high reported rate of 5 to 10%. Even the microvascular, the free flaps we do, the complication rate is 2 to 5%. So the complication of this repair, this treatment, the wound healing, is even greater than free flaps. So this is typically how the patient comes, sometimes operated by me or sometimes by anybody else. So that's not the problem. And it is to avoid this complication that I started using FHL, and it is the topic of my presentation. So herein we can see a dead tendon, then the skin, there is a gap. So now to treat this patient, we have to excise the skin, we have to excise the tendon, we have to give a coverage and then make a new tendon. So now the treatment has become very long. So the reasons why the complications of wound are more, there are many reasons. Some are like common to other injuries like smoking, aged population, osteoporosis, and many a times patient they go to the surgeon with the complaint of pain, and there is a tendinosis and inflammation, and they are prescribed and locally given triamcinolone injection. That is a very important cause of that causes an easy avulsion later on. But otherwise, anatomically, this area is a watershed area supplied by posterior artery as well as peroneal artery. But in the specific region, in the posterior part of the heel, just where the tendon is inserted, the blood supply is very tenuous, and it is this region that is actually at high risk of wound related complications after the repair. One more thing that I observed, the native tendon is applied to the posterior the fascia, and when the foot is plantar or dorsiflexed, it doesn't tent up. But when we repair the tendon, we can see that tendon is detached from all its attachments, and it becomes very tented. Like if you don't, say for example, repair the pulleys in a flexor tendency, it tends and becomes very tight. Similarly, this tendon, after the repair, upper primary repair, it really stretches, and it is always felt that the skin is tight. So these are the things that prompted me to use the flexor hallucis longus tendon. So again, I have already said the objective of the study is to mainly concentrate on closed injuries with a tendon gap of more than 3 centimeters. And injuries, these injuries are, most of the injuries, not all, are a result of avulsion of the TA following local injections, or sometimes in old patients with osteoporosis, even on trivial ankle strain, the tendon was avulsed. Patients with skin that is scarred due to previous surgery or attenuated because of use of steroids. And the caveat is all my patients, they just needed day-to-day activities. None had any, athletic aspirations, or they were not trekkers or not young individuals. So the surgical procedure, the standard incision for tendo-Achilles is either a midline incision posteriorly. Sometimes it is slightly medially made. In my opinion, whether it is midline or medially made, it doesn't make any difference. For me, I do it medially because it is easier to get the FHL tendon. Definitely, the other thing is the incision is smaller in length and is more proximal. The reason for it being more proximal is that in this group of patients, I am not going to the to find out the distal end of the tendon where the tendon is inserted, because I expect that either there is no tendon on the insertion or a very small stump which anyway I am not going to use. And more importantly, I just the thought is that the minimum dissection of the most vulnerable area is required, and that is the reason I do not dissect on the most distal area of the skin. After the tendon is, delivered, then those tendons that are unhealthy due to tendinosis, we debride it, and once we debride, the gap even becomes more and more. It is very important to debride this tendon because the patient had originally come for pain. So if you do not debride it and use this for primary repair, the pain will always be there. These patients, they also require debridement of the bone, and that can be done through the using a bone nibbler through the original incision. There is a group of patients where the injury was not because of an inflamed tendon, and in all these cases we see that there is a fibrous part of tendon or fibrous part which is bridging the avulse tendon and the calcaneum. It is actually not the tendon, but it is a fibrous part. So, but I do not cut it. I use it for augmentation with FHL that I will describe now. So, surgical process, there are 3 incisions. One incision posteriorly, which is slightly smaller, medial, and FHL is identified. It is quite straightforward. FHL lies with FDL and TBL is posterior tendons. And once we identify FHL and pull it, the great toe as well as all other toes will flex. So to be sure, we have to go to the next step. Then we make 2 more incisions. One in the instep area and one at the base of the great toe. So the base of the great toe gives the final, that it is the FHL tendon. But in the center there is something called the knot of Henry, where the FHL and the tendons, the FDL tendons, they are intertwined. So it is not possible to, dissect out.
Can you please be a little quick?
Sure. Where was it? So it is not possible to dissect out the tendon, so we have to sharply cut it. And once the tendon is out, we have to make a drill hole in the calcaneum with a K-wire and followed it with a cannulated drill. And subcutaneously pass the tendon mediolaterally and bring it back into the wound. Once it is back in the wound, we can either join it with itself, or we can join it with itself and suture it with the proximal stump, or we can use it to augment the primary repair. So these 3 types of uses can be done for FHL, and we can see that the most hypovascular area, there is no incision there, and so the chances of bone related complications are minimum. These are the final suture lines, and these are already I have described. Post-op protocol is same as for any other tendo-Achilles repair, so there is no difference in those. Wound-related complications, that is the most important part of the study. Most of the patients had no complications, only one had a small complication of discharge, but it was handled. The pain relief was good, and the most important tiptoe stance was attained for all the patients by 4th or the 5th month. Quickly, the advantages of using FHL, that it fires in the same phase as gastrocnemius and soleus. It is proximal anatomically, and it is a very strong plantar flexor when compared with peroneum. And these are the advantages. And to conclude, for certain patients, definitely, if we use FHL for our repair of tendo-Achilles, it gives us another option and reduces the complications. Thank you so much.
Thank you, Dr. Thakur. Now we invite Dr. Mahesh Janga, and he will speak on Dr. Pradeep Singh.
Dr. Varun Saini. I am an associate professor at Homeopathic Cancer Hospital. We are a unit of TMH Mumbai, a template of TMH Mumbai, situated in New Chandigarh. We were operational last year. Until now, we have done around 300 reconstructions. We are a pure oncology center, and majority of our times we are confined within the oral cavity, and at times we are presented the opportunity to step outside the oral cavity, which forms the tip of our iceberg, and I will be presenting that tip in front of you today. For this cap defect, transposition flap would be the ideal option. A trilamellar upper eyelid defect, more than 80% of the upper eyelid gone. The cutler beard flap is the ideal. The only drawback is that it is to be done in 2 stages, but the reconstruction is worth the 6 weeks of eye closure. Just a short video. Barely perceptible scars after the reconstruction of the upper lid with the cutler beard flap. Similarly, full thickness lower lid defect. Principles of replacing like with like always stay. The lower eyelid was reconstructed first. The lining and support provided by parietal mucoperiosteal graft and the skin cover provided by the Mustardi flap, and fairly aesthetic post-operative results. A skip flap was used for a cheek cutaneous defect, Mustardi flap for a cheek defect, cervicodeltopectoral flap for a submandibular defect, chest wall sarcoma post-resection, opening us the intrathoracic atlas in front of us on table. Reconstructed first the rigid reconstruction done with the PMMA sandwich between 2 proline mesh and cover provided by free LT flap. And we were lucky to have all this implant pass by without any infection. Similarly, another case, the rib was reconstructed, then customized implant, and again the solid chest wall cover provided by a PMMA sandwich. This time the view was more into the axilla, and the ultimate skin cover was provided by the free LT. The patient smile says more than I can say. A shoulder defect encroaching into the nape of neck. We need to be aware of our reconstructive options. We were looking for donor vessels in this case, and our head neck colleagues suggested that the transverse cervical artery can be useful. Similarly, back defect. The patient was 12 kgs lighter after the excision of this defect. Bilateral mycutaneous LD flaps were swung across in an interlacing fashion. Post-spine surgery wound is since covered with a mycutaneous LD flap, again an LD flap for a shoulder defect. For an upper back defect, trapezius mycutaneous flap. For a flank defect, reverse LD flap. And for a massive chest wall defect, VY advancement LD flap was done. This patient was a nulliparous 22-year-old medico, in which we used the ALT flap for breast reconstruction. And similarly, for other cases when we have used ALT flap for breast wound, post-mastectomy massive wounds cover. DIP flap was used for a chest wall cover. For breast reconstruction, we have a relatively small numbers only. In the very few cases, LD flap used for breast reconstruction, a DIP flap, another DIP flap which was used for breast reconstruction. Coming to limb reconstruction, an important decision which is to be made regarding the donor vessels. For this, knowledge of the relevant anatomy is useful, and then one should proceed to exploring accordingly. In this case, the profunda brachii, the profunda branch of the brachial artery was used. In this case, the recurrent branch of the radial artery was used for the coverage of the defect around the elbow joint. A reverse radial flap being used, an ulnar artery perforator flap, a skip flap for a forearm defect. Another massive tumor. Patient was 10 kgs lighter after the tumor excision, and a different view into the anatomy atlas this time. The abdomen was laid open, first covered with the bilayer mesh, and to our luck, the left ALT was injured during the primary tumor excision, but the right ALT and TFL were able to cover the defect, and surprisingly the entire donor site and the defect were closed, and there was no residual donor site. And just a small video. These might look like very small steps, but these are coming from a patient who is walking after 1 year, being confined to bed in supine position. An inguinal mass in a patient with very limited local options due to previous extensive burns in the region. The talar extension of the rectus abdominis flap was used. The flap was folded upon itself to cover the wide defect in the inguinal region. A pudendal flap being used for testicular transposition. It was a case of necrotizing fasciitis, and the testes were positioned in the thigh, and later when they were repositioned they were covered with the flap. Pedicle DLT for a medial thigh defect, for an interior thigh defect, and for a posterior thigh defect, a patient needing brachytherapy, medial gastrocutaneous, the medial gastrocnemius flap. The fairly good result, I would say. The same gastrocnemius can be brought anteriorly also. This was a nearly circumferential extensive defect covered with a free ALT, and the various ALTs used for the lower third defect extending onto the foot and the dorsum and heel and the instep area. But the weight bearing part of the heel, nothing replaces the instep island flap based upon the medial plantar artery. That was just a walkthrough through the minority of our cases. I'd like to thank my entire team, which makes this all work out. And we have been fortunate to have 3 fellows. We are accepting more. Thank you for the organizers to give me this opportunity. Thank you.
Thank you, Dr. for exhaustive display of lab. Thank you so much.
Parliament Secretary Court first, with the permission of the chair and the president.
Okay, start. Kindly start.
So yesterday we have a EC meeting. And in the EC meeting, I would like to thank Dr. Atul Parashar, our past president. He has given us 2,03,000 to the corpus of the APSI and Northern APS. And at the same time, he has proposed to use this fund as a CP Thani Young Classics Award, and he will talk about it later. And in EC meeting, we have decided that we have not filed the income tax return for last 2 years. So Ramneesh is going to file the return for 2022 and 23 and 23-24. So statement has been given to him, and he is going to file these returns. And we found that the receipts of the Northern APS is still very old one, and it is carrying the name of Dr. Vijay Ved. So now we are going to print new receipts as well. And if anybody has any objection, then they can say, I hope. And there was a proposal during the EC meeting regarding the one assistant to the secretary or to the president for the daily day-to-day basis work, which we did not file the return for last 2 years, and interacting between the various office bearers, and if any new member come, sending them the mail or sending them the certificates. For that, we require one assistant. So for that, EC has decided that rupees 10,000 per year can be given to the secretary, or we can appoint a person for 10,000 rupees per year for that. For maintaining data and record of the NZAPS. So we would like to take permission from the GP for this. Thank you very much. And we got a proposal from Uttarakhand Association, Uttarakhand Classification Association. They want to become the member of the Node Zone, and this time they sent few paper as well. But we have not included their paper in best paper because they were not part of the Node Zone. So we have given them the proposal that if they send us a request on their letterhead that all the classes are from the Uttarakhand, they want to join Nord Zone as a Nord Zone, they want to become a Nord Zone member. So we have asked them if they give us the application to become a member of the Nord Zone. So can we make them the member of the Nord Zone? It is open to the GP.
Yes. But do they have their own registered association or?
Yes. Earlier they were in the UP chapter, and for last few years it is divided into Uttarakhand and our UP chapter separate. So they do have their own Uttarakhand association as well. So once they approached us, so then I asked them, you just give us all the members list to us and send on your agenda that you want to become a part of this.
It should be, we should get a request from the association with the signature from secretary and president. And
so they will be maintaining their association as such. But sir, what is the constitution for North Zone? Is it specified that only these states can be included? So, because if Uttarakhand is as yet not included, so we'll have to amend it.
No, actually, earlier when the association was made, there was no Uttarakhand.
Uttarakhand to baad mein na, it was a part of UP.
So what is the constitution? Like J&K, Punjab, Haryana, Himachal and Chandigarh.
Yeah.
These are states. So if it is specified, then we'll have to make an amendment.
I think we have
bylaws are already there. You can just go through the bylaws. If there is anything written specifically related to the state, then we will have to amend that part. But provisionally, as if GBM clears, we can
always make
them
changes
and make
changes.
Yes.
So okay, we go through the bylaws as well.
I think first of all we should receive an official communication from their association.
Exactly.
In that they will have to have a meeting where they have an agenda, merger with the North Zone Association. Then that meeting, the minutes of that meeting.
So they are not mergers. It is not mergers.
They will be maintaining their own association, but they will become a part of the North Zone. For
Part of the North Zone.
For
Okay.
example, we have a Patiala Plastic Surgeons Association.
No, but we don't have a Haryana Association, Punjab Association like that. We have only North chapter, North Zone. They can be.
They can have their own also. It's a registered association. They can have their.
No, as a member, as an individual, they can be a member, but whether we are
members of any committee.
Of any committee.
Yeah, whatever is formed. That's fine.
So the past over. And then we discuss about the journal. Ashish was suggesting about starting a journal, but then we discussed among EC, so we thought let's keep it newsletter for a few months, and once we get the response, then we will move to the journal. So what is the suggestion about this? Yes, please.
Still, we can go with the newsletter only.
Yes.
For some more year. If the organization has 100 plus
So,
capacity.
yeah, exactly the same suggestion was given by the EC as well. And now, I think this is all from my side. Should I announce the R.L. Muchanda Best Paper Award?
Sir, any update about the website? Who is maintaining?
Ashish is maintaining website and he is regularly doing it. And this time, this year we have made approximately 12 new members, and he is going to update all these members after this meeting because we have to take approval from the GG. So till now I have got 12 applications for this year, and we are planning to, because we are keeping the assistant, so that assistant is going to contact new people, those are coming to that particular area to become a member. So we are going to run a drive about that also. That's why we need an assistant. Like suppose in Punjab, 15 new plastic surgeons came. So we asked, like in Ludhiana, we asked Rajneesh कि यार कौन-कौन नया है बता दे हमको. So he will give all the names and numbers to that particular person that we are going to appoint. He will contact them and ask them to become a member. So we are planning to run a drive like this so we can increase our numbers. Yes. So we have 12 new members which has applied for membership before the GP. Dr. Tarush Gupta, Dr. Navneet Sharma, Dr. Tushar Patyal, Dr. Tarun Chaudhary, Dr. Samik Sharma, Dr. Sumit Singh Gautam, Dr. Farooq Ahmed Bhatt, Dr. Mahesh Jangra, Dr. Ritu Bhatt, Dr. Akash Sarangal, Dr. Ritvik Kaushik, Dr. Arush Pasricha, and Dr. Thakur Kasu. So I think this was my report, and now voting for executive. We have this year we have 2 posts, one for the VC and 2 for the executive. And for the VC post, vice president post, we got 2 applications. One from Dr. Sanjay Soni and one from Dr. Umar Baba Farooq. So house is open for that.
I propose the name of Dr. Sanjay Soni for the post of Vice President.
Okay, and Dr. Farooq, I think he is not here.
No, he is not. Physically, he has to.
So, because in the EC we decided that they can discuss among themselves, and we should not go for the voting because it is a small association.
Yeah, I think this is a very good idea. See, we are already holding this conference in.
So I propose the name of Dr. Prashant Yagi for EC. He has worked very hard as organizing secretary in this year.
Done. And the other name, Dr. Sohail, he was interested.
Dr. Sohail Zoor.
He was here yesterday. He registered for the conference.
He has presented a paper also.
Yes.
Baki लोगों के present. Anybody from the floor, in case he wants to propose, वो कर लो.
Yes.
Anybody from the floor? Anybody who has completed 3 years?
Yes.
Prashant and the.
Okay, done.
Prashant.
So done. Okay. So now I request Dr. Rakesh Jindal for the president's speech, and then he will hand over his Mendelian to Dr.
Thank you very much. First of all, I am very thankful to all my seniors and colleagues who have come from far off distance to Karnal. It is really my great privilege to say thanks to all of them. Special thanks to Dr. Karun Agarwal, Dr. Ravi Mahajan, Dr. Rakesh Ken, Dr. Manu Rajan, who came on my special request. Further, I would like to give a lot of thanks to Dr. M.K. Garg, who is patron of our conference. He was chief guest. He is director of Kalpana Chawla Government Medical College. He gave all the support to me in free hand to do anything. I am really indebted to him. Then I will like to thank Dr. Sunil Gaba, who has maintained each and every aspect of the scientific program. In a day, at least 4 to 5 times, he gave time to talk to me and to make a paper. So I am really thankful to Dr. Sunil Gaba, who made all his efforts to finalize the scientific program. Then I would like to thank Dr. Nivesh Agarwal, who is the co-chairperson of this conference, who is head of Department of General Surgery at Kalpana Chawla Government Medical College, Karnal. He looked after all the arrangements, like the arrangements in the auditorium, audiovisual, everything he managed so finely. He gave me 2 consultants and 4 residents to look after the conference. So his 4 residents were available over the registration counter and the stage and everywhere. Dr. Utkarsh was there, who looked after the stage. His associate professor and Dr. Deepak Singla looked after registration counter, professor of surgery here. All of them helped me a lot. Without their help, I could not have done this. Dr. Prashant, a very close friend, he gave me all his help as organizing secretary. All the times he was helpful, he gave all his time. Further, I would like to thank Dr. Divyanshu Kalra, who is our young surgeon in Karnal, and whenever I gave him any job, he did it well. So I'm really thankful to all of you. And last but not least, Dr. Atul Prashar. So whenever I ask for any help, like the previous year designs and this and that, whenever I asked him, he gave me very promptly. So many our designs were copy of the last year. So all the time he helped in providing me the designs. Tata Ajata Shastru Kapoor, he was always helpful. We talked many times. Dr. Sanjeev Uppal sir and Dr. Ajata, they well planned the cultural activity. So I cannot name all due to paucity of time. So I am really thankful to all. So now declaring the award, Dr. Uday stands the first. Dr. Uday, is he here? And Dr. Vandana stands second.
Yes, everyone, please look here.
डॉक्टर महाजन करेंगे मैंने डालनी है
नहीं सर नहीं आपने डालनी है आपने पहले नहीं एक्चुअली प्रेसिडेंट हैंडओवर करनी है पीछे से सर ਤੁਸੀਂ ਪਾਓ
मैं पाऊंगा
मैं ओके असिस्ट करता हूं
नहीं बैठ के पाओ यार नहीं फोटो नहीं ना आएगी
ਤੁਸੀਂ ਖੜੇ ਹੋ ਕੇ ਬਾਅਦ
तू खड़े हो जा
सर खड़े होके आप डाल दीजिए फिर बैठ के दोबारा नहीं पिक्चर हो जाएगी हाँ यस चलो अब बैठ दीजिए नहीं पिक्चर हो जाएगी क्या हो गया यस सर प्लीज वन मोर माला पैकिंग है वन मोर पिक्चर यस सर चलो थैंक यू
अब ऐसे
सीधे लिखे वो पेट का
थैंक यू
सब समझते हैं
सब समझते हैं सर प्लीज फोन बता दीजिए चलो हाँ ठीक है डॉक्टर साहब प्लीज सामने थैंक यू
very much. Thanks everyone. Thanks everyone.
I want to say something about the upcoming conference in Patiala. Chalo.